Well, good afternoon. So I'm going to talk about Section O, Special Treatments, Procedures, and Programs. And what I'm really going to emphasize, or the majority of the presentation will be around the new data elements associated with the ventilator liberation quality measures. The next two slides show the acronyms that are used in this presentation. So in terms of what we are going to talk about this afternoon is we'll talk about the intent of Section O, explain the new items and changes, discuss coding instructions, and walk through several coding scenarios using the new items. I wanted to make sure that we had enough time to walk through scenarios for each of the new data elements for the ventilator quality measures, and we are planning on doing that in this presentation. So at the end of this presentation, you should be able to be fluent in talking about the changes to Section O, articulate the purpose of these new coding options for each of the new items, apply coding instructions to accurately code practice scenarios, and also you should have a good working understanding of the components of the ventilator liberation quality measures. As you know, because most of you are experienced in working with Section O, this section identifies any special treatments, procedures, and programs that the patient received during their stay following, including spontaneous breathing, trial for ventilator liberation, and IV vasoactive medications. But before we get into the new quality measures and those ventilator associated items, we'll talk about an overview of the new items in this section. So one of the new items is IV medications, vasoactive medications. And I'll go over this in more detail, but there are two data elements with O0100H IV medications being the gateway question, if you will, or the gateway item, and then the more specific O0100H2A vasoactive medications. And the IV vasoactive medications was added to the data set because it is a risk adjuster for the ventilator liberation outcome measure, which we'll be talking about in a few minutes. This slide is just an overview of the new data elements associated with the quality, the process quality measure for ventilator liberation, and I'll be going over each one of these data elements in more detail. And this slide just shows the snapshot of the ventilator liberation outcome measure, O0200. And this is the new discharge assessment data element. Lorraine talked about this earlier today, but I just want to point out that the two data elements that you're currently familiar with in version 3.0, I call them F3 and F4, ventilator weaning and non-weaning, those have been removed from version 4.0 of the data set, and they've been replaced by this new data element, O0150A, invasive mechanical ventilation support upon admission to the LTCH. The next few slides, I'm going to provide an overview of the ventilator liberation quality measures, both the process and the outcome measures. The Donabedian model of structure, process, and outcome provides a framework for the ventilator liberation measures. The structure component of the structure component is that the patient is admitted to the LTCH. The process component is related to initiating liberation from the ventilator, or as you can see in the slide, the quality measure compliance with spontaneous breathing trial by day 2 of the LTCH stay. And then the outcome component is the end result of the patient due to care received at the LTCH, and for the purposes of this discussion, it's the quality measure ventilator liberation rate, which is the outcome measure. The first measure, compliance with spontaneous breathing trial by day 2 of the LTCH stay, which includes tracheostomy collar, or continuous positive airway pressure, or CPAP, measures the facility level compliance with spontaneous breathing trial by day 2 of the long-term care hospital stay for patients on invasive mechanical ventilation support upon admission, and for whom at admission weaning attempts are expected or anticipated. There are 2 components to the process measure. One is the percentage of patients assessed for readiness for a spontaneous breathing trial by day 2 of the LTCH stay, and the second component is the percentage of patients ready for a spontaneous breathing trial who received a spontaneous breathing trial by day 2 of the LTCH stay. Patients included in Component 2 comprise a subset of the population in Component 1. While all patients admitted on invasive mechanical ventilation are included in the denominator for Component 1, only those patients who were found ready for an SBT are included in the denominator from Component 2. The outcome measure, ventilator liberation rate, is the percentage of patients who are alive and fully liberated at discharge. The denominator exclusions for these measures are patients who are not, this is for the process measure, patients who are not on invasive mechanical ventilation support, which when we get into specific coding, it's on the slide, O0150A equals 0, or patients on invasive mechanical ventilation support who were non-weaning, which data element would be O0150A equals 2. The measure will be calculated quarterly using a rolling 12 months of data. All LTCH stays, except those that meet the exclusion criteria that I just mentioned, are included in the denominator and are eligible for inclusion in the numerator. For patients with multiple stays, each stay is eligible for inclusion in the measure. This slide shows the numerator and denominator for Component 1 of the process measure, percentage of patients assessed for readiness for SBT by day 2 of the LTCH stay. The numerator is the number of patients who were assessed as medically ready for an SBT by day 2 of the LTCH stay, plus the number of patients with documentation that were assessed as not medically ready for an SBT by day 2 of the LTCH stay. The denominator includes those patients admitted to the LTCH on invasive mechanical ventilation that have any possibility of liberation and includes all patients admitted on IMV support for any duration during the reporting period, minus patients for whom weaning attempts were not expected or anticipated at admission. This ventilator-related process quality measure is important for encouraging implementation of evidence-based weaning guidelines through implementation of trials of unassisted breathing and early assessment of weaning criteria in order to decrease LTCH patient exposure to adverse ventilator-associated morbidity and mortality. The anticipated improvement in quality is an improvement in timeliness of weaning and ventilator liberation for patients admitted to LTCHs on invasive mechanical ventilation. Additionally, facilities can use results of this measure to improve early compliance with evidence-based weaning guidelines and develop ventilator weaning quality programs. In an informal conversation with a colleague in the Boston area in an LTCH, she has reviewed some of these guidelines, and her organization is now in the process of looking at their weaning protocol so that it is more in line with the 2-day breathing trial. So we're already starting to see people thinking about changing their practices based on this measure, but also the evidence. This slide shows component 2 of the ventilator liberation quality process measure, and the numerator is the number of patients who received a spontaneous breathing trial by day 2 of the LTCH, and the denominator is the number of patients who were deemed medically ready for the SBT by day 2 of the LTCH stay. The next slide shows the ventilator liberation quality outcome measure. And this particular measure, the ventilator weaning or liberation rate, assesses the proportion of patients discharged alive from an LTCH who are fully liberated or weaned. It reports the facility-level ventilator liberation rate for patients on invasive mechanical ventilation support upon admission to the LTCH. A patient is considered fully liberated or weaned if he or she does not require any invasive mechanical ventilation support for at least 2 consecutive calendar days immediately prior to the date of discharge. Patients are excluded from the target population if they meet the following criteria. So the first one would be, as we go, you'll see in the next few slides around the data elements, the O0150A, which is spontaneous breathing trial by day 2 of the LTCH stay. The invasive mechanical ventilation support upon admission to the LTCH equals 0, or no, not on invasive mechanical ventilation support. Or the other exclusion criteria is spontaneous breathing trial by day 2 equals yes, meaning non-weaning. So in other words, no weaning attempts are expected or anticipated for this patient at the time of their admission to the LTCH. And similar to the process measure, this measure is intended to promote weaning efforts and encourage quality management of LTCH patients on invasive mechanical ventilation. Of note, or I'd like to make a special note, that if the patient was fully liberated and alive at discharge, then this would be considered a successful liberation. Even if the patient elected to be terminally weaned and survives beyond the discharge, then the patient would still have a successful liberation since the patient was alive at the discharge. Also note that the expired assessment does not include the ventilator liberation rate O0208, and we'll discuss this item a little more in detail later in the presentation, and you'll have some opportunity to practice coding a scenario. The next slide shows the categories and the specific risk adjusters that will be applied to the outcome measure. And so, as you can see, functional abilities and goals, specifically the GGO100B, which Ann went over earlier today. Active diagnosis are risk adjusters. I talked about the cancers in my presentation this morning, heart circulation categories, neurologic, the specific data elements are there, and post-transplant. And then for special treatments and procedures from Section O, IV vasoactive medications, and also dialysis. So these are all risk adjusters that we'll be using once we have enough data to begin to calculate the measures. So now we're going to do a couple of coding. Well, not yet, not quite yet. So this is just an overview of what the data set looks like for version 4.0. Again, you're very familiar with this. We have the non-invasive ventilator data element, which includes BiPAP and CPAP, is familiar to you and is on the current data set. I already mentioned for other treatments, the IV medications is new, as is H2A vasoactive medications. And these are continuous infusions of vasopressors and inotropes. And we'll go over the coding a little bit later on. The remaining data elements in this section are familiar to you, and then also you have Z, none of the above, which is also familiar to you. As you also know, for Section O, these data elements are included as the treatments, procedures, and programs affect the patient's ability to liberate from invasive mechanical ventilation and or perform self-care and mobility activities. As with all data elements on the LCDS, you're going to review the patient's medical record to determine whether or not the patient received or performed any of the treatments, programs, or procedures during the 3-day assessment period. For dialysis, you will check it if it is part of the patient's treatment plan, and this is new and not new and has not changed. For respiratory treatments, O0100G, non-invasive ventilator, BiPAP, and CPAP, so you would check these off for any type of continuous positive airway pressure or bi-level positive airway pressure or BiPAP respiratory support service. This item is coded if the patient puts on or removes his or her own BiPAP CPAP mask, or if the LTCH staff applies it for the patient. As I previously mentioned, O0100H and O0100H2A are new data elements for the ventilator liberation quality measures. You are going to code both of these data elements if the patient is receiving an infusion of IV vasoactive medications. So these two data elements are risk adjusters for the new ventilator liberation quality outcome measures. So these items are intended for patients that are on invasive mechanical ventilation and are expected or anticipated to wean from the ventilator. They're very specific to that measure. Examples of IV vasoactive medications may include, but are not limited to, dobutamine, norepinephrine, milrinone, and dopamine. Moving on to dialysis. Dialysis in this instance refers to treatments of hemofiltration, intermittent or continuous, slow continuous ultrafiltration, or better known as SCUF, hemodialysis, and continuous ambulatory peritoneal dialysis. And this item may be checked if the patient performs his or her own dialysis. And also currently on the current version and in the new version, the TPN data element has not changed, and you're going to code total parenteral nutrition if the patient receives parenteral or intravenous feeding. And as with other data elements in the LCDS, you would check O0100Z if none of the if the patient is not on any of these treatments or received or performed by the patient. So now we'll go on to coding scenarios. And I will tell you, I'm having trouble when you reading your responses, and they're going to try and make the print bigger for those of us that have aging eyes. But that's not going to happen this afternoon. So if I'm going to look at the barcode and see your responses the best that I can, even with my glasses on. So in the first coding scenario, Mrs. L developed acute renal failure related to excessive use of nonsteroidal anti-inflammatory drugs for her arthritis. She receives hemodialysis 3 times per week. So how would you code O0100? Would it be A, check G, non-invasive ventilator, BiPAP, CPAP? B, check H, IV medications. C, check J, dialysis. or check Z, none of the above. And I can see everyone has checked, I can see it, has checked, it is larger, Bridget, checked off dialysis for 100%. And that is correct. And it's correct because this is part of her treatment plan. In the next scenario, Mrs. C has been unable to eat or ingest adequate nutrients since her bowel surgery. Mrs. C receives TPN using a peripherally inserted central catheter that infuses her nutrients 24 hours a day. How would you code O0100 in this scenario? Would it be A, check G, non-invasive ventilator, B, check J, dialysis, C, check N, total parenteral nutrition, or D, check Z, none of the above? And almost 100% selected C, which is the correct response. And again, it's correct because this is part of her treatment plan. In the next scenario, Mr. D is being treated for hemorrhagic stroke. He does not require mechanical ventilation, IV vasoactive medications, dialysis, or TPN. So how would you code this data element? Would it be A, non-invasive ventilator, B, dialysis, C, total parenteral nutrition, or D, check Z, none of the above? And Z is the correct answer. Everyone's at 100%. And Z is the correct answer because this patient does not require any of these treatments. In the fourth scenario, we have Mrs. J was admitted to the LTCH, recovering from septic shock, and is on invasive mechanical ventilation. Her blood pressure was stable upon admission to the LTCH. On the second day of her hospitalization, Mrs. J's blood pressure decreased to 80/50, and norepinephrine was administered via central venous catheter to treat her hypertension. How would you code O0100 in this scenario? Would you check A, H, IV medications, B, check H2A vasoactive medications, C, check Z, none of the above, or D, both A and B? And I'm glad to see the responses are changing because we just went over that. And so the majority of you did select D, both A and B. So as I said, the IV medications think of it as a gateway question to this section, and then at this time it has one data element under it, which is the IV vasoactive medications. So you would check both, as Mrs. J received norepinephrine, a vasoactive medication that was administered through a central venous catheter for her hypotension. So this is what the new data set looks like for the ventilator process measure. And now we're going to walk through each of these data elements. And the rationale for these items are included because they document the use of invasive mechanical ventilation support upon admission to the LTCH and the implementation of a spontaneous breathing trial by day 2 of the LTCH stay. This item also documents the facility's implementation of evidence-based weaning guidelines that occurred as early as is beneficial to the patient during the LTCH stay when the patient is assessed as a candidate for weaning upon admission. And we have received questions about why day 2 versus day 3. And day 2 was determined from we had 9 technical expert panel reviews in developing these quality measures, and with an extensive review of the literature and international consensus that it's better to wean the patient off of ventilation as quickly as soon as they're ready, and 2 days was felt to be an appropriate time frame that we wanted to achieve. So the first data element, O0150A, you're going to code 0, no, not on invasive mechanical ventilation support if the patient was not on invasive mechanical ventilation support upon admission to the LTCH. If you code no in this data element, this ends the data collection for O0150, and you're going to skip to O0250. You're going to move on to the influenza vaccine data elements. Another example of when you would code this item as 0 would be if the patient was admitted to the LTCH and was not on invasive mechanical ventilation, but required intubation, say after the first 8 hours of their stay. This is because the patient was not on invasive mechanical ventilation support upon admission to the LTCH. So what's important about this first data element is that the patient arrives in your organization invasively mechanically ventilated. You're going to code this data element 1, yes, weaning, if the patient has any type of electrical or pneumatic closed system mechanical ventilation device that delivers oxygen to your patient who is unable to support his or her own respiration, and for whom weaning attempts are expected or anticipated at the time of admission. So there's two things to keep in mind. The patient is admitted to the LTCH on invasive mechanical ventilation with the, maybe the admission order or the care plan such that this patient is anticipated or expected to wean off the ventilator during their LTCH stay. If you code this one yes as weaning, then you're going to move on to O0150B, assess for readiness for SBT by day 2 of the LTCH stay. You're going to code 2 on this data element, non-weaning, if the patient has any type of electrical or pneumatic closed system mechanical ventilator support device that delivers oxygen to a patient, same as I previously say, and for whom weaning attempts are not expected or anticipated at the time of admission. So patients who are, as an example, patients who are chronically ventilated in the community or at a facility, or who have progressive neuromuscular disease such as ALS or irreversible neurological injury or disease or function such as high C2 spinal cord injury. So these may be just examples of patients that might be considered non-weaning. It's not to say that we know from clinical experience that there are patients with ALS that have successful weaning. If you code this item as 2, yes, non-weaning, this ends the data collection for O0150. And then, as I said, for the first data element, you're going to skip to the influenza vaccine data element. I've mentioned this already, the point that I just want to make from this slide, because we've gone over the first bullet, is that documentation in support of this item should be recorded and dated by day 2 of the LTCH stay, where day 1 is the day of admission. If item O0150A is marked either no or yes, non-weaning, then completion of items O0150B through O0150E is not required for the patient. If item O150OA is marked yes, weaning, then you're going to proceed to item O0150B. 0150B. The next data element, O0150B, is spontaneous breathing trial by day 2 of the LTCH stay. And this is, you're assessing the patient for readiness for a spontaneous breathing trial by day 2 of the LTCH stay. And again, I want to emphasize that note day 2 equals the date of admission to the LTCH, day 1, plus 1 calendar day. You're going to code no on this data element if the patient was not assessed for readiness for an SBT by day 2 of the LTCH stay. And if you code no, then this ends the data collection for this entire section, O0150, and you're going to skip to O0250, the influenza vaccine. If you code 1 yes, the patient was assessed for readiness, then you're going to continue to O150C and ask the question about deemed medically ready for SBT by day 2 of the LTCH stay. If you select no for O0150B and items O150C through O150E are not required for the patient, and you're going to skip to the influenza vaccine. If O150B is marked yes, then you're going to proceed to O0150C. And O0150C data element asks if the patient was deemed medically ready for the SBT by day 2 of the LTCH stay. You're going to code 0, no, if the patient was not deemed medically ready for an SBT by day 2 of the LTCH stay. If you code this data element no, then you're going to continue to O0150D. Is there documentation of the reason or reasons in the patient's medical record that the patient was deemed unready or not medically ready for an SBT by day 2 of the LTCH stay? If you code 1 yes, if the patient was deemed medically ready for SBT by day 2 of the LTCH stay, you're going to continue on to O0150E and assess the patient or the documentation that the SBT was performed by day 2 of the LTCH stay. The next data element in this section is O0150D. Is there documentation of the reasons or reasons in the patient's medical record that the patient was deemed medically unready for SBT by day 2 of the LTCH stay? The purpose of this particular item is to identify whether the reason or reasons that the patient is deemed medically unready for SBT by day 2 of the LTCH stay is documented by the LTCH by the end of day 2 of the LTCH stay. The specific reason or reasons are not required in the assessment. You're going to code this data element 0, no, if there is no documentation of the reason or reasons that the patient was deemed medically unready for SBT by day 2 of the LTCH stay. And if you code this one as 0, you're going to skip to O0250, the influenza vaccine. If you code 1 yes, if there is documentation that the patient was deemed medically unready. And if you code this one as yes, then you're going to also skip to O0250, the influenza vaccine. For item O0150, documentation in the medical record indicates explicit physician or physician designee documentation of the reason that a patient was not deemed medically ready for SBT by day 2 of the LTCH stay. The last data element in this section, O0150E, asks if the SBT was performed by day 2 of the LTCH stay. You will code 0, no, if an SBT was not performed by day 2 of the LTCH stay, or code 1, yes, if an SBT was performed by day 2 of the LTCH stay. Only one item, either O0150D or O0150E, should be coded. The response to item O0150C determines which one of these items is coded on each patient's assessment. So now let's see how good of a job I've done. And we'll code some scenarios. So in the first scenario, Ms. K, excuse me, Ms. K is a 32-year-old female who's being discharged from the acute care hospital after an acute episode of respiratory failure secondary to pneumonia. She was diagnosed with cystic fibrosis and has had recurrent respiratory infections over the course of 6 months. She was intubated in the emergency department and transferred to the ICU, where she was treated for her pneumonia. After several failed attempts to wean and extubate, Ms. K underwent surgery for placement of a tracheostomy tube. She remains fully ventilated and is being transferred to the LTCH for weaning. Ms. K was admitted to the ventilator weaning unit, where she is expected to liberate from mechanical ventilation. This is recorded in her discharge summary as well as in her care plan from her admission to the LTCH. So as this is a rather long scenario, I'd refer you to your handout in your folder if you want to look at some of the details of this scenario. So how would you, whoa. Let's see. We're really ahead of the game here. Okay, whatever. So how would you code O0150A? Are you going to code it A, 0, no, not on invasive mechanical ventilation support, B, code 1, yes, weaning, or C, code 2, yes, non-weaning? And you are correct. You are going to code 1, yes, weaning. And this is the appropriate response because Ms. K is admitted to the LTCH with the intent to wean from the ventilator, and this information was documented in her care plan. In the next scenario, you will be asked to assess the patient's readiness for a spontaneous breathing trial, O0150B. I seem to be going ahead too fast. Okay. Mr. J, I'll just read it. Mr. J is a 24-year-old male who transferred to the ventilator unit at the LTCH for weaning and physical therapy to increase his endurance. He underwent a bone marrow transplant approximately 6 weeks ago and is deconditioned due to chronic shortness of breath that does not allow him to perform most activities of daily living. His current admission to the acute care facility was due to acute respiratory distress. He was admitted to the ICU with a diagnosis of idiopathic pneumonia syndrome. During his ICU stay, he suffered several failed attempts to liberate from mechanical ventilation. On admission to the LTCH, he was receiving full mechanical ventilation through a tracheostomy tube. There is documentation on his admission summary and in his LTCH care plan that he is anticipated to liberate from mechanical ventilation. The LTCH physician orders the weaning program that requires assessment for an SBT by day 2 of the LTCH stay. Mr. J is expected to wean from mechanical ventilation. He was not assessed on day 2 of his LTCH stay due to a clinical change in his condition. His assessment for readiness for SBT occurred on day 4 of the LTCH stay due to 48 hours of severe nausea, vomiting, and diarrhea, which temporarily increased his shortness of breath and exacerbated his deconditioned status. Due to his high respiratory rate and a decrease in blood pressure, he did not meet criteria for assessment for an SBT. How would you code O0150B? Code 0, no. Assessed for readiness by day 2 of the LTCH stay, or code 1, yes, was assessed for readiness by day 2 of the LTCH stay. Okay, and the correct answer is 0, no. He was not assessed for readiness for SBT by day 2. This data element would be coded 0 no, as Mr. J was assessed for readiness for SBT on day 4 of the LTCH stay due to a clinical change in his condition that did not allow him to be assessed by day 2 of the LTCH stay. Ms. T is a 32-year-old female with cystic fibrosis. She was discharged from the ICU yesterday and admitted to the ventilator weaning unit at the LTCH. She had a stable first night and transitioned from the ICU ventilator to the LTCH ventilator without issue. She understands that she passed the SBT criteria and is medically stable and ready to transition to spontaneous breathing via a tracheostomy mask. The registered nurse and respiratory therapist coordinated the trial for an SBT to begin when Ms. T finished with her routine morning care. How would you code O0150C? Was this patient deemed medically ready for an SBT by day 2 of the LTCH stay? And we reached 100% consensus that you would code 1 yes. This is correct. And it's correct because Ms. T passed the SBT criteria, she's medically stable, and she's ready to transition to spontaneous breathing via tracheostomy mask. In the next scenario, we're going to talk about depicts a scenario around documentation. So it's O0150D, and Mrs. F is admitted to the LTCH with a diagnosis of hypercarbic hypoxemic respiratory failure secondary to a chronic obstructive pulmonary disease exacerbation brought on by flu-like symptoms. While Mrs. F was in the ICU, she required intubation and mechanical ventilation. Mrs. F was extubated twice and was placed on non-invasive ventilation. Both attempts at non-invasive ventilation led to elevated partial pressure of carbon dioxide in her O2 blood, PaCO2 levels, which led to her being reintubated and placed on mechanical ventilation. After the second failed attempt to liberate her, she underwent a procedure to insert a tracheostomy tube. She was admitted to the LTCH yesterday and is expected to wean off mechanical ventilation as documented in her admission care plan. Mrs. F was assessed for readiness for SBT on the day of her admission to the LTCH. She did not pass her SBT assessment. Her assessment included evidence-based guidelines to assess her readiness to perform an SBT. It was noted in the medical record by the respiratory therapist that Mrs. F had significant autopositive end expiratory pressure, or auto PEEP levels, and breath stacking. The physician ordered her applied PEEP to be increased to a level above the acceptable high range for readiness to perform an SBT. The treatment plan is to increase her bronchodilator treatments and to stop her steroid taper. The physician order and the documentation of breath stacking and significant auto PEEP are documented in the medical chart record. How would you code O0150D? Is there documentation of the reason or reasons in the patient's medical record that the patient was deemed medically unready for SBT by day 2 of the LTCH stay? So A would be code 0 no, B would be code 1 yes. And the response is B, yes, which 100% achieved. And the reason that this is the appropriate response is that there is documentation in the medical record that Mrs. F was deemed medically unready for an SBT by day 2 of the LTCH stay. She did not pass her SBT assessment. Her assessment included evidence-based guidelines to assess her readiness to perform SBT. The physician ordered her applied PEEP to be increased to a level above the acceptable high range for readiness to perform the SBT. And the treatment plan is to increase her bronchodilator treatments and to stop her steroid taper. The physician order and the documentation of breath stacking and significant auto PEEP are documented in the medical record. And In the fifth scenario is an example of how to code O0150E. SBT is performed by day 2 of the LTCH stay. Ms. M is an 82-year-old female admitted to the LTCH with a diagnosis of non-small cell lung cancer. After a successful pneumonectomy procedure, she was transferred to the surgical ICU. While in the ICU, she required high levels of oxygen to maintain normal oxygen saturations. She eventually required intubation and ventilation for respiratory distress. Mrs. M's course was then complicated by the development of acute respiratory distress syndrome. She was treated for ARDS and slowly improved over the course of 2 weeks. During this 2-week period, she underwent a procedure to place a tracheostomy tube. Yesterday, she was discharged to the LTCH, where she was admitted to the ventilator weaning unit. It is documented in her care plan that she is expected or anticipated to liberate from mechanical ventilation prior to her discharge from the LTCH. Ms. M was assessed on the day of admission and determined to be medically ready for an SBT. However, due to inconsistent communication among the health care team, Ms. M did not perform the SBT until the 3rd day of her LTCH stay. So how would you code this data element? Was the SBT performed by day 2 of the LTCH stay? A, code 0, no. B, code 1, yes. And that code 0, no, is the correct answer because the SBT was not performed on Ms. M by day 2 of the LTCH stay due to a miscommunication. So that ends the data elements associated with the process measure for liberation. Now we're going to move on to the data element associated with the ventilator liberation rate or the outcome measure. And this just shows the data elements, and we're going to walk through the rationale and the coding responses. As this slide shows, this item is used to determine the facility's rate of discontinuation of invasive mechanical ventilation, which is used to calculate the ventilator liberation quality measure. These are the responses that are included for this data element. So in coding this data element, you have 3 choices. You're going to code 0, not fully liberated at discharge, if the patient required partial or full invasive mechanical ventilation support within 2 calendar days prior to discharge. You'll code this data element 1, fully liberated at discharge, if the patient did not require any invasive mechanical ventilation support for at least 2 consecutive calendar days immediately prior to the discharge date. And you're going to code 9NA if the patient was non-weaning or not on invasive mechanical ventilation support on admission. So in other words, going back to the process measure data elements, O0150A equals 2 or 0 on the admission assessment, then you're going to code this data element as 9, not applicable. So you can see how this data element corresponds to the first data element of the admission assessment, the patient's mechanical ventilation support upon admission to the LTCH. The patient is not on invasive mechanical ventilation support, or the patient is intended to wean from mechanical ventilation upon admission to the LTCH. Patients who were coded as non-weaning on admission and improved unexpectedly and are fully liberated at discharge would still be coded as 9NA, since these patients were identified as non-weaning on admission, and they are excluded from both the process and the outcome measure. So these are just a few coding tips for O0200A. To code 1, fully liberated at discharge, The patient must not require any IMV for at least 2 consecutive days immediately prior to discharge. I've also been asked if fully liberated within this time frame includes decannulation. And the answer to this question is no. The patient needs to be free of invasive mechanical ventilation at least 2 consecutive days immediately prior to discharge. So they do not need to be decannulated to meet this criteria. This slide is in response to questions we received from the December training because people asked us about what 2 consecutive days mean prior to discharge. And one of the questions was, is it correct that 2 calendar days prior to the date of discharge does not mean 48 hours? And that is correct. 2 consecutive calendar days does not mean 48 hours. So as an example, if a patient was liberated from the ventilator any time on Wednesday and discharged any time on Friday, then this would qualify as at least 2 consecutive calendar days, Wednesday and Thursday, prior to the date of discharge, which in this example is Friday. Another question that arose was, does the day of discharge count as the 2nd calendar day? And the answer to that is no. It is 2 consecutive calendar days plus the date of discharge. So now we're going to do some coding scenarios. Ms. K is a 32-year-old female who is being discharged from the LTCH to a skilled nursing facility. She was admitted to the ventilator weaning unit after her ICU stay at an acute care hospital. Ms. K was diagnosed with cystic fibrosis complicated by multiple recurrent respiratory infections, and she had a tracheostomy tube placed while at the acute care hospital after she failed several attempts to liberate from mechanical ventilation. While at the LTCH, Ms. K is successfully liberated from mechanical ventilation. Ms. K will be discharged to a skilled nursing facility for tracheal decannulation. She has not required invasive mechanical ventilation for at least 2 consecutive calendar days immediately prior to her discharge. In this scenario, how would you code O0200A, invasive mechanical ventilator liberation status at discharge? A, code 0, not fully liberated at discharge. B, code 1, fully liberated at discharge. C, code 9, non-applicable. Or D, enter a dash. And the correct answer, which most of you selected, is B, code 1, fully liberated at discharge. And this is the correct response because Ms. K did not require invasive mechanical ventilation for at least 2 consecutive calendar days immediately prior to discharge and was fully liberated at discharge. In the second scenario, Mrs. F was admitted to the LTCH with a diagnosis of hypercarbic hypoxemic respiratory failure secondary to a COPD exacerbation. While Mrs. F was in the ICU, she underwent 2 attempts to wean fully from the ventilator and had 2 unsuccessful trials of BiPAP post-extubation. She was admitted to the LTCH with the expectation of fully liberating from invasive mechanical ventilation. Despite several attempts to wean her from the ventilator, she was unable to maintain normal PaCO2 levels for greater than a few hours. She remained fully ventilated until the time she was discharged to the acute care facility due to sepsis. How would you code O0200A, invasive mechanical ventilator liberation status at discharge? A, code 0, not fully liberated at discharge. B, code 1, fully liberated at discharge. C, code 9, and A. D, enter a dash. And the correct answer is A, code 0, not fully liberated at discharge. In this scenario, the item is coded as no, as the patient was not fully liberated from mechanical ventilation at discharge to the acute care facility for treatment of her sepsis. Coding scenario number 3. This is the final coding scenario in this presentation. Mr. G was diagnosed several years ago with ALS. He has been managing his respiratory system adequately using a non-invasive ventilator. Over the past 2 months, it has become increasingly difficult for him to maintain ventilation using a non-invasive ventilator in the home without developing pneumonia and atelectasis. He was recently admitted to the ICU of an acute care hospital for elective surgery to place a tracheostomy tube and subsequently placed on full invasive mechanical ventilation. After his 3-day stay in the ICU, he was stable on appropriate ventilator settings and transferred to the LTCH to prepare his family and caregivers to care for his needs in the home setting. How would you code this particular scenario? A, not fully liberated at discharge. B, code 1, fully liberated at discharge. C, code 9. And A or D, enter a dash. And code 9 and A, not applicable, is the correct answer. And it's correct because Mr. G is on invasive mechanical ventilation and he was determined to be non-weaning upon admission to the LTCH due to his medical condition. So to summarize this section, I have presented how the treatments, procedures, and programs listed in 00100 can affect the patient's ability to perform self-care, mobility, and ventilator liberation activities. I have also presented new data elements 00100H, 00100H2A, and 00150A through E as the new items on the admission assessment. 00150 collects information on a facility's implementation of a spontaneous breathing trial for patients on invasive mechanical ventilation. And the new data element 00200 is the new item on the planned discharge and unplanned discharge assessment and collects information on ventilator liberation status on discharge. As always, you're going to develop your own individualized action plan that works best for your setting and your facility, but I recommend that you review all items added to Section O. You determine the methods for reviewing the patient's medical record to determine whether the patient received any of the treatments, procedures, or programs at the time of admission, particularly around documentation around deemed medically unready or deemed medically ready for the SBT. For dialysis, you are going to check if it's part of the patient's treatment plan, and if the patient doesn't receive any of the listed treatments, then you're going to check C, none of the above. I already mentioned this one, but again, to reemphasize, determining methods for reviewing the patient's medical record to determine whether an SBT was performed by day 2 of the LTCH stay and whether the patient was fully liberated from the ventilator at discharge. And then I would suggest practice coding a variety of scenarios with staff. And there's more scenarios in the LTCH LCDS version 4.0 than what I've covered today. And I believe I have a few minutes for questions. And Anila's shaking her head. Okay. I'm sure questions will arise as you begin to collect data on these measures beginning in July. And so if they arise, please feel free to submit them to the LTCH QRP Help Desk, or as you think about questions over the next day that you're here, please feel free to submit questions. So thank you.